Good afternoon. DP is 28 weeks pregnant and she's had 2 prior births, both being preterm labor at 32 and 34 weeks gestation. She came to the hospital stating she was having 2 hours of painful contractions, and upon your exam, you found her cervix to be long and closed. In this case, it appears the only symptom that the patient is having is ongoing painful contractions. We really don't have a lot of information on this patient, so it seems like more testing is warranted before we prematurely diagnose her with preterm labor. Although she is very high risk for preterm labor because she's had 2 prior preterm labors and preterm births, we don't know if she's actually in true labor at this point in time. It's normal for women in the later half of their pregnancy to have Braxton Hicks contractions. True labor contractions result in cervical changes that are regular and increase in frequency, intensity, and duration. We don't even know if her contractions stopped when she came to the hospital. We don't know if the contractions are regular, if they're increasing in frequency, increasing in intensity, or if she's having any type of cervical changes. It's important that we assess her and the baby further. We should be monitoring her vital signs frequently. We should be monitoring the baby's heart rate frequently. We should have her on the monitor to monitor her contractions. In order for the patient to be diagnosed with preterm labor, she needs to be having 4 or more contractions in a 20-minute period, or 8 or more contractions in an hour, with cervical dilation up to 3 centimeters or more, or a cervical length of less than 2 centimeters, or a cervical length between 2 and 3 centimeters with a positive fetal fibronectin. So before we go on and diagnose her with preterm labor, I think the patient first needs another exam where we can obtain a vaginal swab for a fetal fibronectin. That's a marker to detect preterm labor, and we should also do a transvaginal ultrasound to determine the patient's cervical length, and then we should also do a transabdominal ultrasound to check on the baby to make sure the baby's okay and to determine the baby's measurements. If the patient is determined to be in preterm labor, then we need to implement interventions to help prolong her labor and to help optimize her situation, and that doesn't include bed rest. Bed rest is not effective at prolonging pregnancy and can actually lead to increased complications such as blood clots, worsen the mom's mental health, and lead to decreased muscle strength and bone weakening. So it would be inappropriate to send her home on bed rest. If the mom is determined to be in preterm labor, it's important that we start her on corticosteroids to mature the baby's lungs, and then give her prophylactic antibiotics because we don't know if she is positive for group B strep. We also need to start her on magnesium sulfate for neuroprotection of the infant. We need to possibly even transfer her to a hospital that's capable of caring for a premature newborn because the baby will most likely need to be in the NICU for quite some time. And we also need to start her on tocolytic therapy. If we determine that the patient is not in preterm labor, then it's important that we talk to her about progesterone supplementation because she should really continue on where she should be started on and continued on progesterone therapy to help prevent preterm labor until she's 36 to 37 weeks pregnant. So I think we have more diagnostic testing to do before we can determine that she's in preterm labor or not. Thank you.